thank you so much for this opportunity to present to such an esteemed faculty and audience. And following on from a fantastic Claire, I'll aim to do the name proud. So I've been asked to speak on a formula for return to sport stroke work. So I've been thinking about this for quite some time. I put my head to it and I came up with the following thing. So if you've got a pen and paper, you can write this down. This will ensure a successful return to work and sport. Clearly, I'm joking. I've got no idea what that represents actually, but it does look fairly complex, and that's the intention really to convey. It's really a difficult, certainly in 30 minutes anyway, to get somewhere close to a formulaic approach for a successful return to sport or return to work, stroke activities of daily living. And each setting is going to be different, each patient's going to be different, and each goal and indeed the tests selected are different. Now, we obviously have some formulae or approaches within different injuries and rehabilitation programs. So, for example, the ACL is very well researched. We've got a decision-based model here by Creighton, published in 2010, that takes together different types of factors that need to be included in that decision-making process, and then the sub-factors within that. We've also got the brilliant Ardern et al. Paper from 2016, another Claire, Monopoly, maybe there's something in the name, I don't know. But again, that presents similar things in terms of that decision-making process for return to sport in an ACL population or ACL reconstructed population. But to try and convey that to a broad spectrum of patients with different MSK surgeries, injuries, considerations is probably a futile exercise, actually. And in discussing and thinking about this formula, and for return to play or return to work, I think there's kind of two elements here. One is that decision-making process on if it's appropriate, safe to enable them to go back to work or to play. Or indeed, are we thinking about the optimal preparation to enable that return to work or return to play, return to sport? And indeed, that it does inform the latter. So I think to try and get the most out of this 30 minutes, I think probably to focus on this optimal preparation with the consideration of that decision-making for return to play would probably be a more fruitful 30 minutes than discussing the different paradigms and different models for different conditions, because we won't really get too much detail. So let's just get some context in the talk and what we're thinking about. So we're thinking here, obviously, about rehabilitation, and a fantastic presentation before on Claire and looking at the patellofemoral joint and those specific considerations. But broadly speaking, the aim of a rehabilitation program is to enable that patient or that athlete to return to activities of daily living or to sport safely, effectively, and ideally as quickly as possible. Now, we'd all love to kind of be in this situation where everything's in place. It's idyllic. We can sit back and relax because we've got all the resources we need. We've got the personnel. The patient does what you want them to do. You've got the finances and all the equipment. But in reality, it's going to be a version of that, and some less fortunate than others. So the reality is that we still have this remit of the individual to return to function, performance, or play as soon as possible. But oftentimes, particularly in busy, let's take NHS practice, you might only have a single session per week, if you're lucky, with that individual, yet the goals remain the same. So we have competition for limited resources and time and expertise. You've got different patient profiles with different goals and different starting levels of conditioning. So often that task can be quite a really difficult one to juggle and to manage properly. But that's not to say there aren't a few key things that we can follow and strategies to follow to enable that success to be or more chance of success. So increasing the chances of success and making a more manageable situation for this preparation for return to sport and to work is, it kind of starts really with the determination of what that rehabilitation program is aiming to do, commensurate with the aims of the patient. So they're, such an important part within this model. We can't forget them. They're integral to it. And then we can start to plan to optimize the efficacy of those rehabilitation interventions. So in terms of a formula or a model, I think one that we could look at today would be a fairly simplistic approach, one that we acknowledge first and foremost the goals of the plan, of the individual, and where we're headed. Then I think a framework of conditioning efficacy would help formulate thoughts around that determination of or enhancing efficacy of intervention, and a system really to go through to use within your rehabilitation practice would be the focus of today. And then also thinking about the tests and the validity. So just to kind of focus on goals for a minute, as I said, yes, it's a goal of the rehab plan, but it's also the goal of the patient and the goals of the patient, and they're central to this, absolutely central. And indeed, think as well that those, depending on how long you have with the individual and how long that plan is, that endpoint might change. So we're determining an endpoint, but that could be variable. And just to note here, there's the whole psychology of that individual as well, which makes up another course. In fact, we run a course on the psychology of buy-in, but that's for another talk. So we're acknowledging that the goals are super important, probably the starting point for determination of every point thereafter. And that can be, as I said, variable, dependent on the patient profile. It could be, improvement of pain or perception of pain, or learning to live with a level of pain, return to play or high level competition. It could be just to walk the dog. And once we've got that in place, then we can start to think about design of a rehabilitation plan to enable a successful return to whatever those kind of endpoints are. So we're going to talk a little bit about conditioning efficacy and what that represents. Here you can probably get an idea of the concept from the imagery on the right-hand side here. Efficacy is the ability to produce a desired or intended result. So therefore, conditioning efficacy is the ability to achieve the performance or indeed the rehabilitation outcomes through that conditioning prescribed. And a lot of what I'm talking about in this section here is published in a recent book chapter of the Elsevier's new sports medicine textbook. Although it's sports medicine and sport performance, the principles are absolutely relevant to every patient population. So within this conditioning efficacy paradigm, we've got three key things. Everybody loves a Venn diagram, don't they? Oh, maybe not everybody, but I do. So we have planning and design as one part of that. We've got the basic principles, and then we've got the performance demands and injury risks. And that conditioning efficacy, the ability to almost hit the nail on the head with what you're trying to do with your rehabilitation program, kind of represents that sweet spot in the middle. So what we're going to do is just look briefly at each one of these premises here, flesh it out a little bit such that it can be applied to rehabilitation programming, and you have a better chance of being efficacious and effective within that whatever rehab setting you're in. So planning and design, what is the focus of your rehabilitation plan and how is that progressed and adapted over time? And this is going to be commensurate with the goals, and particularly the goals of that individual. So I've taken here, in terms of the rehab priorities and things that you're thinking about within a rehabilitation program, just from a neuromuscular level, but clearly there are other parameters that you might need to incorporate within a rehabilitation program, dependent on the individual and the condition, etc. But it might be that we have, from a neuromuscular perspective, we want to improve neuromuscular performance. Well, what does that mean? We've got strength, we've got rapid force production or rate of force development, we've got even the switch on times of the muscular to consider, and then clearly all of that has to happen within a controlled, regulated way. So that's the sensory motor performance or proprioception. And to say here, and I'm sure everybody's absolutely aware of it, but just that we don't have that magic one exercise or one approach that's not changed, that enables an optimal improvement in all outcomes. And that would include other outcomes that you're thinking about as well, regardless of whether that's, a sporting population or a non-sporting population or an older adult population. And I highlight this because, this is something that I see a lot. I think we're getting better at, I suppose, critiquing this in the therapy and rehab world, but I still see a lot of it. This is your typical 3 sets of 10, let's say for the knee extensor group, and it gets given out on an exercise sheet, and maybe you're doing it 3 times a day or 3 times a week, to whatever. But you've got this 3 sets of 10, and you might get given an exercise or resistance band, and that exercise sheet gets given to everybody who needs that exercise, because the focus of that exercise is what? Well, typically people say it's for strength, but it's not a strengthening exercise. Clearly you will get, in really deconditioned populations or those novel to exercise, you will get some adaptation on some things, but that will quickly plateau. And if you remember the characteristics of those individuals, they're very different from one another. So it might be representative of a stimulus in one type with one individual, and maybe not even doing anything for benefit in highly conditioned individuals, but yet still we don't acknowledge that within the programming, nor is there any determination of progress or indeed overload. So I'm saying that it's important to think about the planning and design such that you've got every chance of success to achieve the outcomes that you want. So we've got a clear vision of these rehabilitation goals. If we want to improve muscle strength, then we need to be specific about the programming of that. And one thing to take away with any intervention that you're designing would be this principles of training. You get these things right, you're going to be successful. So you've got specificity, overload, and progression, and you can apply this to all manner of exercise interventions, or indeed, I suppose, interventions on daily life. Specificity refers to the specific training intervention will improve specific outcomes. If you want to improve muscle strength or you want to improve balance, you need to have that specific goal. Once you've got that specific goal and that marker, then you have to have the right overload. The overload represents in this case, neuromuscular challenge. So you have to set a training regime of greater intensity than the individual is accustomed to make sure that adaptation occurs. And Claire touched on it in her talk earlier about, you need to really work the musculature to fatigue to promote that adaptation. If you don't have the overload, there will be no adaptation. And then you get those 2 things right, your patient will progress. So that's great, but we need to program that within the rehabilitation program. So constantly assessing and improving the prescription by increasing the overload. And that can apply to any manner of exercise that you're prescribing. So that's a planning and design. What is it that you want to achieve? And structurally, how are you going to set up your program, your exercise to achieve that? Then we come to basic principles. Do we understand what muscle strength is, for example? I'm just using this as the exemplar here, but it applies to all other outcomes. What is it that we're dealing with? Muscle strength is, or maximal muscle strength to be perfectly accurate, is the ability of a muscle or muscle group to develop a maximal contractile force against a resistance in a single contraction. So when we're measuring muscle strength within research settings or indeed within clinic settings, if you've got the dynamometry to do so, it's often judged as the peak torque or the newtons produced from a single maximal contraction or averaged over a few single maximal contractions. Now that we understand muscle strength, we understand how intense basically the muscular contraction is. Does it make sense to provide 3 sets of 10 of a resistance band that presents really no stimulus for strength? Or it's very, very easy to do and they can do more. Why do they stop at 10? So this is something you can take away and apply it to your resistance training in rehabilitation programs. This is a repetitions maximum continuum adapted from 2 sources, developed way back in the 1980s, but the premise still holds today. You've probably seen this before, I imagine, if you're in rehabilitation settings. If you haven't, basically on the top here, the numeric indicator is the number of repetitions of an exercise you can do until you can't do any more. The size of text indicates the size of response. And here, if we want to improve muscle strength, you see that represents really 3 to 5 repetitions maximum. That means lifting a resistance up to 5 times, but you can't lift it 6 because it's just too heavy. So that challenges a lot of thoughts and you think, oh my goodness, I can't do that with patient populations because they're in pain and they've got joint restrictions or whatever it is. But just to know, if you're at that 3 sets of 10 to 12, it's not really doing anything optimally. And in actual fact, more recent research is showing that 12 repetitions maximum is more of a muscular endurance type exercise and activity. So we need to be more specific and have specificity and create the right overload. And incidentally, there are a multitude of ways you can adapt exercise to enable that overload to occur. So you can change range of motion if they're symptomatic at some points. You can change the mode of muscle activation. It doesn't have to be concentric, eccentric. You can do isometric or purely eccentric. You can change the speed of muscle activation. You can train the opposite limb for cross-education. Again, quite a lot of information within there, but just to illustrate, just because that individual is a patient and they may have symptoms doesn't necessarily mean you need to ditch that prescription. And then finally, looking at performance demands and injury risks. This is completely related to, again, the goals of that individual. Do you understand the demands of the sport if you're dealing with an athlete, or the activity if you're a non-athlete? From a both performance and functional need, what are they going back to, and what do they need to be resilient to be able to cope with to mitigate future injury? So it's requiring, if you have an individual that has an osteoarthritic knee and actually you're going to do some rehab with them or conditioning with them or prehab, whatever the best word is, to try and just maybe offset maybe a total knee replacement or get them into a better condition to go into a total knee replacement. So preoperative status determines postoperative outcomes, get them stronger, maybe reduce their pain a little bit. They want to be able to walk the dog perhaps on unstable ground for more than the 5 minutes that they can currently. What is it that they need to have in place? They need to be strong and have the dynamic joint support. They also probably need to be able to cope with unstable ground. So you're thinking about perturbation, training, etc. And the same principle applies to that elite athlete, except slightly different demands and risks. Such then, you've got that knowledge, you can design the exercises appropriately to promote the deployment of the newly formed muscular capacities in that unpredictable environment. So 1, understand the environment that they're going back to, the demands and the risks. 2, you're designing the exercises to enable that. And then 3, you kind of put them in those situations that's controlled, but still represents a challenge and maybe a slightly less expected challenge than in a standard situation. Then you establish, when you're thinking about what you need to do with them and what you'd like them to commit to doing, you need to establish this hierarchy of importance of which factors are most important at what stage throughout the rehabilitation program. You try and do all things all at once, you'll do a lot of things very poorly. Our body pools, resources, it's only got so many. So, you might find that the adaptation is curtailed across a multitude of parameters. You might overload not just the neuromuscular system, but the patient. You give them reams and reams of exercises, they're probably not going to do, any. So thinking about what we need to do and when, and then we can design the program to achieve this. And incidentally, this sounds like a lot of work, but in the longer run, and even in the medium term, it saves time because you're not managing patients on the fly. You've got a planned approach. You know what's going to be happening throughout that period of rehabilitation. Yes, there might be changes from day to day, but you've got an end point that you're working towards, a basic structure that you're following, rather than kind of you're dealing with the situation on the day. And in terms of what's usually done, and I'm taking a resistance-based model here because we're talking about strength, typically what's prescribed is generally we focus on endurance. So we've got a pyramid here, what forms a foundation and the majority of intervention, and then it kind of tiers up. And oftentimes we're focusing on muscular endurance. Then we notice that the musculature is slightly smaller and we've lost muscle cross-sectional area, so we probably need to focus on that. And then we've got strength and then maybe power if needed. And I don't think that's the most useful way to look at things. And particularly as well, when we're thinking about, when we're getting into the most important part of that triangle, which I think is certainly from the strength perspective anyway, is that, as I mentioned before, if we're high loading heavily these patients, we want to, and they go, oh, that's sore when my knee flexes to 90 degrees, then typically what happens is people want to reduce the load to make it less symptomatic. But by reducing the load, we've lost the specificity. You said you wanted to improve muscle strength. So now that patient's doing 14 repetitions, fairly symptom-free, but they're not working muscle strength. So you've lost the purpose of the exercise unless you adapt exercise. So what I think is a more useful way to look at programming, and this is a whole talk in itself, is that I think strength forms the foundation upon which a multitude of other abilities are built and enhanced. So we should look at muscle strength first and foremost, and even more so in those older populations where we might be thinking people are frail and that we need to look after them, and they're sarcopenic, and often they are losing strength because they're disengaging from exercise more. It should be something that we focus on first and foremost, particularly when we see the evidence that relates to not just increased knee pain associated with muscle weakness, risk of falls. We're even talking about all-cause morbidity, so all-cause mortality as well as morbidity. So we look at muscle strength first, then we can make that program individualized. And we've got all manner of prescriptions that are valid. So it could be that they do strength, then power, then hypertrophy, and go back to strength, and you can see where I'm going with this. Or indeed, you might just do a little bit of that. But again, having that plan in place and periodizing it enables you to be successful at more things. And in the chapter, I present this system here, the hierarchy of importance, that helps consolidate and align your thoughts. You've got loads of things to think about, particularly in post-operative, and you've got loads of different parameters to think about. And these are just some of them. So once we've got the pain under control and we're happy with range of motion and function, that acute phase is past, then think about the things that we're left with and where we're headed with the rehabilitation program to determine, ultimately that return to function or to sport. We might have muscle strength. We've got maybe some power, rate of force development, and then we've got sensory motor performance or proprioception, and that might be related to performance as well. The greater the size of arrow here, the greater the focus in that rehabilitation program. So we've got the early phase here, coming through to the late phase or end stage. And this is a model that can be applied to any rehab program. It's, just the length that will be different. So first and foremost, we're thinking here that, that sensory motor ability, the ability to walk maybe on unstable ground, to respond to perturbations is important. So balance and sensory motor performance is important. But from a functional perspective, going back to being able to, from a sports perspective, decelerate, twist, change direction, and head a ball while slipping, for example, that's not so important right now. And we focus on deploying those capacities in the late stage. But what is important as well in that early stage is muscle strength. So what you'll see is we've got a high focus on muscle strength and a high focus on sensory motor performance. Low focus here on rate of force development or muscle power. And as we go through the progress, if you like, of that rehabilitation plan, the focus changes. Now, the exact focus for your individual can vary dependent on what their goals are. And maybe you don't even do very much of the performance-based tasks. You just want that individual to be able to respond to a perturbation, i.e. Avoid a fall if they stand up out of the chair and trip over the carpet. Still, you will have some perturbation training that represents that challenge, but it's not going to be the same as an elite tennis player, for example. So we've covered quite a few things there. So if we go back to that original approach and model that we're trying to cover in today's presentation, we start this process. Well, what is the formula to enable an individual to return successfully to sport and to work or to activities of daily living? We have the goals. It starts off with the person in front of you, who they are, what the baseline conditioning is, and indeed maybe their propensity to exercise, factor all that in, but what's the goals of the rehabilitation program aligned with the goals of the patient? What's the end point at this moment for that? And then we've spoken about conditioning efficacy, how you can seek to develop your program such that it's got a greater chance of success meeting those goals. So you've got progression within there, you've got specificity within there, you're programming with a view to progression and managing multiple rehabilitation outcomes. And indeed, as well, you've got the overload right for each one of those parameters. Then it comes down to the tests. And as I said, we've only got maybe a couple of minutes left, so it'd be futile to try and unpack this completely, but just be mindful of the tests that you're using to judge that return. Are they valid and valid in the situation that you want them to be valid within? Are they sensitive to change, and what level of change? Are they reliable such that, on repeated tests, they're giving the same, under the same circumstances, the same data? And some of these things might represent limb symmetry indices, functional tests, capacity tests, and self-perceived inventories and questionnaires. So you might have a multitude of those things that make up that battery of tests that help guide your decision to return to whatever it is. So just to sum up there is no single formula to judge return to work or to play. That determination of needs and goals should be on an individual basis and factoring in the patient such that you can develop that plan. And having a systematic and specific approach will greatly, greatly optimize your efficacy and chance of being successful with that rehab and conditioning such that they can return to play or return to work. And the determination of order of importance, and this we're using periodization from the exercise science literature here, but it absolutely has relevance within rehab. It will depend on that individual's needs and goals. So what's the starting point of their physical conditioning and where do they want to get to? And using this concept of conditioning efficacy can help guide effective rehabilitation design and enabling that successful or better chance of success of return to work and play. And just to make sure, there's another discussion on what tests to use. If you're going to be using testing to help judge that or help your decision making in that process of returning to work and to play, make sure you understand the parameters of that test, the validity, sensitivity, reliability, and don't just rely on one single outcome. Take a more wider view. So thank you so much. That's the end of my presentation, hopefully on time. And happy to take any questions.